Nishant, do you hear
Oh,
me?
hi, good morning. Good morning. I guess good evening, Oxel. Yeah, I can hear you. Can you hear me?
Almost. We still here. We just forget what time is it now. From the beginning of the day, we are still here. You see all the colleagues. We are looking forward to hear from you, and we have two patients with us. Two long
Oh,
patients, ladies in front. Thank you for accepting our invitation. Now the stage or the screen is yours.
yeah, sounds good, Oxel. Thanks a lot for inviting me and thank you for the patients who are here. Goxel had asked me to talk about the diagnosis and management of LAM, but have a bit of a perspective on where we are now and where we need to get to from a future standpoint. So I just took that directive and divided it into two halves. So the first half is going to be uh, an overview of where we are with the diagnosis and management of LAM. And the next half will be some bits of where we need to get to from a future standpoint. So the first half may be a bit of a repetition. I'll try to go through this as quickly as I can. So this is something that I'm sure throughout the day you've already discussed, that LAM is a rare lung disease seen almost exclusively in women, most commonly occurs in the reproductive age groups, although we have had patients diagnosed in their teenage years and up to their 70s and 80s. So the age range is wild, although the average age at diagnosis tends to be somewhere in the mid 30s. And if you leave it unchecked, it causes progressive lung destruction over time to where 10 years after the onset of symptoms, about half of the patients are short of breath while walking on a flat surface, and about a quarter of the patients require supplemental oxygen. Uh, Again, this is stuff you likely have covered. LAM is caused by mutations in the tuberous sclerosis complex genes, and I'll refer to this as TSC. There are two known TSC genes, TSC1, TSC2, and a mutation in either one of these two genes, very simply put, leads to unchecked activation of this mTOR pathway. This mTOR is a very central pathway. When mTOR pathway is active, it drives a clonal neoplastic proliferation of smooth muscle-like cells, and we refer to them as LAM cells, that then invade the lung and cause the cystic destruction. So LAM can occur in patients who have underlying TSC, where we call it as TSC LAM, or can occur in women who don't otherwise have TSC, where we refer to as that sporadic LAM. Now, interestingly, in sporadic LAM, only TSC2 mutations have been described. While in TSC LAM, both TSC1 and 2 mutations have been described, but even in that context, patients with TSC2 mutations tend to have LAM more common and tend to have more severe LAM as compared to TSC1 mutations. This is a simplified diagram of what essentially happens in the pathogenesis of the disease. So you have these LAM cells, they start growing somewhere. We have recent data that suggests that this source might be the uterus, but the jury is still out on that. As these LAM cells proliferate, they also secrete lymphangiogenic markers such as VEGF-C and VEGF-D. They gain access to the lymphatics, travel up the lymphatic vessels, reach the subclavian vein, and end up getting stuck in the alveolar capillary. So that's a simplified mechanism of how they sort of reach the alveolar capillaries and then lead to subsequent lung destruction. Some recent data with regards to the prevalence of LAM. So, back 3 decades ago, we thought LAM occurs in about 1 to 2 women per million. And it's interesting if you see this, that in the next decade, this prevalence estimate was around 4 to 8 women per million. And in this decade, the prevalence estimate is really more closer to about 20 women per million. So regardless, it stays a rare disease, but worth mentioning that this is, we see LAM a lot more, or I should say, we recognize LAM a lot more commonly now than we did before. This story is not unique to LAM. The prevalence is not increasing over time. It's just that we have gotten better about diagnosing this disease. And this happens in other rare diseases as well. As the knowledge and awareness about the disease increases, we recognize this more than we did before. So even this 20 per million should be considered a minimal estimate and not necessarily a true estimate of prevalence. These are the various manifestations of LAM that you might encounter on chest CTs or imaging. I shouldn't just say chest. So on the left-hand side is the prototypical LAM cysts. So you have these very smooth, thin-walled cysts that are present uniformly and bilaterally. This is a patient with very mild LAM, but I like showing this because it highlights what the typical cysts of LAM look like. The next panel is someone with a lot more advanced case where you can see almost the entire lung parenchyma is taken over by cysts. The image next to it is showing the benign fat-containing tumors called angiomyolipomas that can be seen in about 1/3 of the patients with sporadic LAM and the vast majority of patients with TSC LAM. So this is a patient with TSC LAM, and you're seeing a large kidney angiomyolipoma. She also happens to have these in her liver. We talked about how LAM cells traverse up the lymphatics. So here's a patient with this is a abdomen MRI showing a very dilated abdominal lymphatic vasculature. Occasionally, you can also see a lymphangioliomyoma, which is sort of a lymphatic collection lined by smooth muscle cells. And as the LAM cells are traversing up the lymphatic channels, if they create a blockage or an obstruction, the chyle or the lymph can start leaking at other places. So this is a common complication called chylothorax, where this chyle is leaking around the lungs. This is a much more rare manifestation where this chyle is actually draining into the lung tissue itself and not around the lung. And lastly, because of these air-filled cysts, they are prone to rupture and cause a lung collapse or a pneumothorax that can be experienced by about half of the patients with LAM. Okay. With regards to diagnosis, I think a key point to mention is that in about 2/3 of the cases, we can diagnose LAM confidently, clinically, without needing a biopsy. So this is a table from the LAM guidelines that we published now close to a decade ago, where it said if you have a CT that looks like LAM in the right clinical setting, and if you have any one of the following 5 features, you can confidently establish a diagnosis of LAM. And those features are: if you have an elevated VEGF-D more than 800, if you have existing TSC, if you have a kidney AML, if you have a chylous effusion, or if you have a lymphangioliomyoma. And in practice, as I said, we think that in more than 2/3 of the patients, we can establish this diagnosis with one of these features. In the remaining 1/3, you may still need a biopsy to confirm. So this is how practically we think about or approach the diagnosis of LAM. Let's say we encounter someone whose clinical features and CT are suggestive of LAM. We start with a detailed history and exam looking for features of TSC. If we find TSC, we have confirmed the diagnosis of TSC LAM. If we haven't, then we check a VEGF-D. We would do imaging of the abdomen. And if there happens to be some sort of a chylous effusion that is easily tapped, we would tap it. And then we look for, are any of these features positive? Meaning, is the VEGF-D elevated? Is there a renal AML? Is there a chylous effusion with positive cytology? If so, yes, we have a confirmed diagnosis of LAM. If we have exhausted all of these means, then before proceeding to biopsy, we take a step back and ask ourselves, do we need a diagnosis? Well, there are 2 layers to this. Do we as a physician need a confirmed diagnosis? And from the patient side, does the patient want a confirmed diagnosis? The implication here being, are we going to treat if we have a confirmed diagnosis? If the answer is no, and that patients are okay with living with some degree of uncertainty, we take a step back and say, let's just check lung function test every few months. If things are progressing, we can revisit getting a confirmed diagnosis. If the answer to this question is a yes, then we proceed with a biopsy. Generally, a transbronchial lung biopsy has a yield of about 50 to 60% in diagnosing LAM, especially if viewed by an expert pathologist. At our institution, we are doing mostly cryobiopsies for these instances uh, and proceeding to surgical lung biopsy only if needed based on the prior results, which is increasingly less and less common. Okay. Let's talk a little bit about the current management, and I'm sure this is something, and this data has been shown already throughout the day, but uh, because of the central role of the mTOR pathway in the pathogenesis of LAM, this mTOR1 inhibitor called sirolimus was then tested uh, in various phases in LAM. I'm only showing you the phase 3 slide and not the prior slides. And so in this phase 3 trial called the MILES trial, 89 women with LAM with moderate to severe disease. So the inclusion criteria here was that their lung function or their FEV1 had to be less than 70% to be considered eligible for this study. They were randomized to 1 year on sirolimus versus 1 year on placebo, meaning no treatment. And then for the next 12 months, both groups were observed without treatment. So if you look at the first 12 months, these circles are the placebo arm and they show continued decline in lung function. The squares are the sirolimus arm, which shows a complete stabilization of lung function. In the next 12 months, where both groups were observed off therapy, there is continued decline in lung function, and this lung function decline is the same in both groups. So what this showed us is that treatment with sirolimus is very effective at stabilizing lung function, but that it is a suppressive treatment, meaning if we want to achieve durable disease control, we need to give this drug on a long-term basis. And based on these results, sirolimus has been approved by the US FDA to treat LAM, and has also been approved in 40 plus other countries around the world, and has really transformed how we care for patients with LAM. I'm going to mention a couple other benefits of sirolimus that we don't often talk about beyond lung function. So we talked about angiomyolipomas, or these kidney tumors that happen in about a third of the patients with sporadic LAM. So this is actually a slide from the CAST trial, which was the phase 2 trial before MILES. Same design, except there was no placebo arm here. So these are about 25 patients who have AMLs. They were treated with sirolimus for 12 months, and then the sirolimus was withheld. And you can clearly see these angiomyolipomas shrunk in size when treated with sirolimus, but rose back after sirolimus was withheld. So the same effect as was seen with lung function. And these angiomyolipomas, they bring with them a risk of bleeding, especially as the size increases. But point of this slide is that sirolimus or everolimus, essentially any mTOR inhibitor, works very well to reduce and stabilize the risk of angiomyolipomas. And that surgery, especially nephrectomies, are very rarely, if ever, needed. It's unfortunate that even in today's day and age, we still sometimes hear these horror stories of patients who have their kidneys taken out for angiomyolipomas. That really should be the last resort and is very rarely needed. We talked a little bit about chylous effusions that can be seen in about 20% of women with sporadic LAM. And curiously, for reasons we don't fully understand, we don't tend to see these complications in TSC LAM. But irrespective, I often hear from patients about, months long of low-fat diet or other dietary interventions or octiotrides or invasive procedures for these effusions, same as AML surgeries, those are very, very uncommon needs. If you think about this as a mechanical obstruction where the LAM cells have basically blocked the lymphatic channel, treating them with sirolimus will shrink them and allow this flow to occur normally. So sirolimus works very well for chylous effusions and should be the drug of choice for problematic chylous effusions. However, it may take a few months for it to take full efficacy. So I'll treat some patients as well at the same time as we treat sirolimus, use sirolimus for chylous complications. This is some emerging data where it appears that sirolimus can also reduce the risk of pneumothorax in LAM. So whether a recurrent pneumothorax can be an independent indication to treat with sirolimus, I think there is more to come on this, but certainly the data from multiple sources by us and others seem to suggest so. And this is data from Kai Feng's group, where it really seems like patients who were treated with sirolimus tended to have a survival benefit over patients who were not treated with sirolimus. And that's impressive because patients with sirolimus tended to have worse disease than patients who were not treated with sirolimus, right? That stands to reason we are going to treat who are patients who have more severe disease. And despite that, there was a survival advantage in the favor of sirolimus. Yeah. And this is my last slide on the present, and is that there are 2 clinical practice guidelines from ATS that were published now about a decade ago. I suppose that should go as a future goal that we need to update these, but and I won't go over all of these. I just wanted to mention these as references for you, and they each of these guideline documents addressed 4 specific questions pertaining to treatment and diagnosis of LAM. All right, let's shift gears a little bit towards the future aspect. And this is not an exhaustive list. I wanted to stay focused on the theme of diagnosis and management. So from a diagnosis aspect, we talked about how the current means are only providing a non-invasive diagnosis in about 2/3 of the cases. I think the clear present need for us is we need to be able to shoot towards a stage where biopsy is not needed for the diagnosis of LAM, and that means we need to identify other biomarkers beyond VEGF-D that can help us get there. And even with VEGF-D, I think we are very familiar with the fact that access to VEGF-D testing is a major barrier, both within US and outside US, and I think that needs to be addressed. In terms of management, I've sort of broken this down into 2 buckets. We talked about a lot of benefits of sirolimus in the past 5 minutes, but there are still unanswered questions about sirolimus in LAM that we need to work on. One, what is the optimal timing to start treatment? The MILES trial included patients who had lung function less than 70%. What about patients who have normal lung function? Should we wait till the lung function reaches 70% before we start treatment? I'm not showing the data in this slide deck, but we have recently finished a trial looking at low-dose sirolimus and preserved lung function. So there is more to come on that. I think we need to use the natural history data that has been established in LAM in multiple cohorts to be able to better predict who is likely to progress and who's likely to respond to treatment, and use that data to guide our management. There is a lot of debate about 1 milligram of sirolimus, 2 milligrams of sirolimus. What is the right dose? What is the right dose for each individual patient? I think we need to come to personalized dosing regimens, and I'm going to show a slide on a potential way to do that. And lastly, we need to establish long-term safety and efficacy of sirolimus. And in the last bucket of the management is we need to go beyond sirolimus in terms of providing more options for our patients. Sirolimus is a suppressive treatment. In an ideal world, we would like to reach a stage, whether individually or in combination with sirolimus, where we have remission-inducing treatments. And and on that, I'm largely going to focus on some innovations in terms of trial designs that we need to work on. Because to me, I think that is the biggest need for the field. So I'm not going to cover all of these in the next 10, 12 minutes that are left for me, but I'll try to hit on some of these aspects. So in terms of biomarker discovery, one of the things that we need to do now is that as the technology and these multi-omics grow, that offer us a very high resolution, high fidelity look at the disease directly from human samples. We all know that the animal models of LAM are not optimal. And so Minzy Guo, who's a bioinformatics specialist at Cincinnati Children's, has developed this prototype model where he's collating data derived from proteomics in the blood and single cell from the LAM tissues, and putting it all together to come up with these biomarker candidates that may have utility in LAM. And so Minzy has already identified a list of these biomarkers that appear to have potential validity in LAM. So they all need to be tested in the lab. They all need to undergo series of future validations. So a lot of work to be done on this, but I think this gives us promise in moving beyond VEGF-D alone as a diagnostic biomarker in LAM. We talked about the long-term safety and efficacy of sirolimus in LAM. So this is some unpublished data from MIDAS registry, which is a NIH and then subsequently LAM Foundation funded registry that recruited about 350 LAM patients with annual data over 20 sites in the US. And so this is data going up to 5 years. And about half of the patients in this registry were on treatment and about half were not on treatment. And you can see that there is stabilization in lung function in patients who are on treatment and a continued decline in lung function who are not on treatment, which is, in a way more impressive than a randomized control trial data, in that in the clinic, there is a clear bias that we are not treating patients who we think are otherwise too mild or doing well. And we are treating patients who we think have more severe disease. And despite that bias, there is a clear benefit in treatment. And this slide shows that the benefit in treatment accrues and keeps on accruing at least until 5 years out. So suggesting to us that the efficacy and safety of sirolimus is quite durable, at least over a 5-year time span. We talked a little bit about prediction models. So this is a model that Anushka and Rhonda and I worked on a couple of years ago, where we used the NHLBI LAM registry. And if we just input some very simple variables like age at diagnosis, baseline lung function, and menopausal status, this can give us a prediction of what is the rate of FEV1 decline that this patient might have. What is the likelihood that this patient might decline beyond a certain threshold of FEV1 decline? And this model is freely available at this website for anyone who wants to access it. And we think this can help make better decisions in the clinic for both patients and physicians. But in terms of the next steps, I think we need to create similar models using, for instance, the MIDAS data to identify patients who are less or more likely to respond to sirolimus. I would like to imagine a state where we can identify patients who are less likely to respond to sirolimus and use them selectively for the next phase of LAM trials. We talked a little bit about the need to get personalized or better sirolimus dosing. And this is at least an idea in our heads that we think that VEGF-D could help us get there. So this is data from the MILES trial, where in the first 12 months, as patients were treated with sirolimus, their VEGF-D levels went down. And as the treatment was withheld, these levels rose back again. So we think VEGF-D is a very sensitive marker to guide the degree of mTOR suppression. This is data from the result of the resveratrol trial, where we had about 25 patients with LAM. They were all on treatment with sirolimus, and about half were on 1 milligrams and the other half were on 2 or more. And if you see here, the patients who were on higher dose sirolimus had a greater reduction in VEGF-D and perhaps a better stabilization of lung function. So A makes us wonder whether low-dose sirolimus that we tend to employ more and more commonly is the right approach for everyone, but also makes me think that if we could use serial VEGF-D levels at each sirolimus dose, we might be able to identify the right dose for any given patient. This is an idea. This needs to be tested, so take it with a grain of salt. Let's shift gear to what I think the biggest need for the field is, which is that we need to design the next phase of trials better. And I won't spend too much time on it, considering it's already late in the day for you guys who have been sitting through this since the morning. So this is a list of all the trials that have been done looking at mTOR inhibitors. We've already discussed that mTOR inhibitors work and are the first line treatment for LAM, so no need to necessarily spend time on it. This is a list of all of the other non-mTOR inhibitor trials that have been done in LAM. And you can see here the mechanisms vary from metalloproteinase inhibition to hormonal therapy to autophagy to multiple tyrosine kinase inhibitors. But the common feature here is they're all early phase trials. They are done on very small number of patients, and most of them are for very small time duration. And I've also summarized this here in that the other key shared features is that these are all therapies that we generally knew that they were safe therapies. Their safety was not necessarily in question, but the trials were designed in this small open label design with safety as the primary endpoint. Our stealth objective here was that we were looking for some sort of magic to make go no go decisions, and these trials were not necessarily powered properly for efficacy. We didn't account for the fact that effect sizes on top of sirolimus are going to be small. So this seems a bit harsh, but just all of this over the past decade does, if you take a step back, make me think like we've been on a road to nowhere, which, by the way, is a real road in the US, if in the state of North Carolina, if anybody ever has the desire to visit. And this is the tunnel where this road to nowhere ends. Anyway, let's come to point. So I think we need to move away from the quote unquote safe agents and embrace that that potential therapies in LAM may come with some associated risks or side effects that we need to manage. I think we need to better use the multi-omics technologies to give us high fidelity targets. We need better endpoints beyond lung function. FEV1 has a ceiling effect, especially with sirolimus, and I don't think that FEV1 can continue to give us the effect sizes we need. I think we need to enrich our cohorts and only include patients who are at a higher risk of decline. So consider using premenopausal patients, consider using biomarkers such as high VEGF-D or menstrual cycle related symptom variability. And I'm going to show a bit of data on all of those. And I think we also need to embrace home-based disease monitoring in a rare disease for more efficient use of time and resources. So this is a slide not meant to be an exhaustive list. This is just meant to illustrate that there is a large gap between the discoveries in the lab and what has been translated to the clinic. This is believe it or not, a simplified diagram of how much we understand the mTOR biology and the subsequent pathways that are deranged in LAM. And at every step, there are potential therapies that one could target or take to the clinic. And a lot of them appear promising. So it's not that we are short of potential targets or therapies to be tested for LAM. Why have these not been taken to clinic? I think we don't know how to properly design trials to answer questions around those, which is why I again I say that the trial innovation I think is the biggest need for the field right now. In terms of cohort enrichment, so this is data from the MILES trial where we did a post hoc analysis after dividing the cohort on the basis of VEGF-D and menopausal status. Let me walk you through because these can be complicated lines. So if we just focus on the left-hand graph, these are patients divided on the basis of the baseline VEGF-D level. So if your VEGF-D levels were low and you were on placebo, your lung function sort of just stayed the same. But if your VEGF-D levels were high and you were on placebo, you declined the fastest. Conversely, if your VEGF-D levels were high, you tended to respond better to treatment with sirolimus. On this side is menopausal status. So if you are premenopausal and on placebo, you decline the fastest, while postmenopausal patients declined slower. But both groups declined faster. So you could imagine a scenario where if you only took patients who have high VEGF-D and are premenopausal, that perhaps you would have a better chance of seeing a signal in the next wave of trials. This is something that we've very recently been working on, where we noticed that about a quarter of the patients with LAM have this very cyclical symptom variability in association with the hormonal fluxes. And if you look at across this table, the patients who have the cyclical variability tended to get diagnosed earlier and also tended to have worse symptoms than patients without cyclical variability. And this made us embark on a prospective study where we took premenopausal women with LAM, segregated them on the basis of cyclical variability or not, and further on the basis of whether they are on treatment or not, to see if this can have prognostic or predictive value. And this is what we found is that similar to VEGF-D, in patients who are not on treatment, patients with cyclical symptom variability tended to have a faster decline in lung function. Conversely, patients with cyclical variability tended to respond better to treatment with sirolimus. So perhaps this could be another very simple patient-reported measure that could be used for future cohort enrichments. And this is just a little bit of data on home-based disease monitoring. So home spirometry was an exploratory endpoint in the resveratrol trial and also in the recently finished MILD trial. So these are 8 patients from the resveratrol trial. The blue line is the office or based PFTs that we do every day. The red lines are from home-based values that patients did. Now notice the absolute value of home spirometry tends to be lower than office-based values. That's something that we have seen in other chronic pulmonary diseases. This is not a surprise. However, the feature of interest in LAM really is not the absolute value, is the trajectory. And if you notice here, the confidence intervals around the home values tend to be a lot tighter than office values. And that's just the value of having too many data points. But the slopes are relatively comparable in home versus office settings. So it makes me think that if we have home spirometry in our early phase trials, we could perhaps make go, no-go decisions in a shorter amount of time and help get to the next wave of trials fast. Okay, I think I've overstayed my half an hour welcome. A lot of people to thank that I, in the interest of time, will not go over for now. The Just one slide on the LAM slash Rare Lung Disease Consortium, which is a network of clinics around the US and around the world helping us do collaborative studies across the spectrum of rare lung diseases. This network has been tremendous in ensuring that patients get high quality care and that this network can help do collaborative trials. And proud and happy to say that Goxel is a part of this network and a cherished member of this network. So thank you very much, Goxel, for everything you're doing. And I'll leave you all here in that while there is a lot of work to be done in LAM, over the past 3 decades, there are a lot of assets that have also been accumulated in LAM. And I don't know that I need to go over every one of them, but I think the sum of these accumulated assets means that all of the remaining work, there is a high likelihood of that achieving success. And there is every reason for us to believe, especially for the patients, that the future of LAM is bright. I'll stop here.
Thank you very much. And thank you for bringing hope into the middle of the meeting. Thank you very much, Nisha.
Yeah. Oh, thanks, Koksal. It's nice to see all of you and have a good rest of the evening.